Welcome, everyone. Thank you for coming to the American Dental Association's Facebook Live event. We're very happy to have you. We are live on Facebook. And my name is Hannah Cho. I'm a fourth-year dental student at Midwestern University. And today we have the pleasure of having Dr. Erin Kennedy here with us. She is one of the co-authors of the recently published guidelines on antibiotics. And we're very happy to have you.
Thank you so much, Hannah, and thank you so much, Midwestern University and the American Dental Association. I'm super excited to be here and chat with you guys today. You're probably wondering who I am. Good question. My name is Erin Kennedy. I work at the Alliance Dental Center in Quincy, Massachusetts, and I'm associated with the state of Massachusetts, working in a practice where we're trying to create oral wellness and total health for our patients and find ways to sustain that and to track that. And as you know, a piece of that is antibiotic stewardship and best prescribing. And so as I've been on this journey as a board-certified public health dentist over the last few years, I've been involved in organized dentistry, I've been involved in clinical practice, and I really have a passion for research and education. And what's really interesting is clinical practice guidelines are where those two passions fuse. So I'm excited to be here with you today, and I'm so excited to have questions later.
Thank you, Erin. So happy to have you here. Just want to let you guys know that we have our Facebook Live audience who are viewing in and tuning in from online, as well as our live audience here today. So if at any point for the viewers online, please feel free to comment and ask any questions in the Facebook Live chat box, as well as for our live audience. At the end of our conversation with Dr. Kennedy, you can please feel free to come down and use the microphone right here to ask your questions or if you have any comments as well. So let's get started. So Erin, how were you involved in the development of the American Dental Association's antibiotic guidelines? It's related to the urgent management of pulpal and periapical pain and swelling.
Yeah, thanks, Hannah. So I was involved because I was a panel member, and we actually had 12 guideline panel members that were a part of creating this guideline. It's really important to recognize that treating tooth pain and swelling often involves an interdisciplinary team. Because the mouth is a part of the body, as we learned from the Surgeon General's report, and more and more we're finding ways to integrate primary care and dentistry and do that in a lot of different and unique ways. And so our panel was just as diverse as it is, or as the team it takes to treat tooth pain and tooth swelling in many cases. And so we had a fantastic group. There were dentists just like me. But there was also an emergency medicine physician. There was an infectious disease doctor who actually had a specialty in infectious disease and practiced internal medicine as well. We also had a pharmacist on our panel and an oral microbiologist. And so as you can see, we brought together a really diverse group of people to help create these guidelines and basically to bring all of these different ideas and perspectives together when formulating these recommendations.
That's really amazing to have such a diverse group of people come together for this guideline. Seeing how this guideline not only impacts dental professionals, are there other organizations that may have been involved in the creation of these guidelines or may have influenced the decisions for these guidelines?
Absolutely. So the way a guideline works is it's not just the panel alone. In fact, the panel is supported by the ADA Center for Evidence-Based Dentistry, the methodology team, as well as the ADA library team as well. And they are integral. We wouldn't be able to do this process without them because they help keep the process objective and unbiased, and they really lead us through this process of creating guidelines that can be applied to your clinical practice. And so we not only work with the ADA, but that core team also reaches out to other stakeholders and other groups like the Centers for Disease Control and Prevention, or the CDC, the American Association of Endodontists. There's other organizations as well that we reached out to. And what's really amazing is that we solicit input from these organizations for those recommendations, but in addition to that, we get public information. So there's a survey online where people can chime in and give feedback and give input well before we ever publish these guidelines. And what's really unique and what I've come to learn more about throughout this process is we also reached out and solicited information from patient advocacy groups like the Peggy Lillis Foundation. And if you know anything about the Peggy Lillis Foundation, it actually goes towards advocating and educating patients, providers, and politicians and policymakers on the effects of C. diff and what it can do to the individual patient. And so I challenge you to check that out, but also recognize that these guidelines was not just a group of 12 to 20 people that came out with these recommendations. It was it was an entire professional effort from across the country to develop and bring these guidelines and recommendations to you.
Wow, a whole team effort right there. That's really great. So what clinical scenarios do these guidelines cover?
Okay. There are 5 recommendations that you're going to find, and I think you received swag already, am I right? So you can just, I love educating, so here we go. You can bring out your little worksheets, and you're gonna see these, and I think it's going to be a little bit helpful for you, whether you're on Facebook or you're here live with us, because there's 2 scenarios for which we have recommendations. One where dental care is available, and one where dental care is not available. And the terminology that you're going to find in the guideline is something called definitive conservative dental care. And what we mean by that, or the definition for that inside this guideline, is when a patient can receive immediate dental care that involves either a pulpotomy, a pulpectomy, a non-surgical root canal treatment or therapy, or an incision and drainage of an abscess. And so we look at these treatments when dental care is immediately available and when it's not immediately available, and then make a recommendation on whether antibiotics should be used or not be used.
That's really great that you guys covered in rural areas, say for example, they may not have immediate access to dental care and things like that. So that's a really great thing to be able to cover that.
Hannah, that's exactly the point. You know, there are certain areas in the country where, or certain patient populations, or even individual patients that can run into a scenario where, yes, they can get immediate dental care, but then everyone in the room knows that there are a lot of indications where a patient might not be able to receive immediate dental care. And so acknowledging that that is an unfortunate reality is something that's really important to be a part of these guidelines, because then we can also make sure we're educating providers and practitioners on those scenarios. And one that comes to mind for me is emergency departments or emergency room physicians and doctors. So,
right, for sure.
Absolutely.
That's really great. Could you elaborate a little bit more on the different types of diagnoses for these urgent management of these?
So when we're talking about tooth pain and localized intraoral tooth like swelling around your teeth, what we're really looking for is whether the patient has symptomatic irreversible pulpitis or necrotic pulp. Those are the pulpal conditions. And then the periapical conditions that we're looking at are symptomatic apical periodontitis and localized acute apical abscess. And so for each of the conditions where dental care is either available or not available, and these diagnoses, we're able to then make a recommendation for that.
Okay, that's really great. And I realize it's hard to summarize these guidelines because it's so immense and such thorough investigations into it. But is there any way that you can summarize these?
Absolutely. Okay. So part of the reason why we're doing this Facebook Live event and we've involved all of you here is because I think it's really important when we have evidence and guidelines to make it accessible to all dental team members. Because a piece of this is, and a big piece of this is shared decision making among our patients. And so in order to do that, we all have to be on the same page, and we all need to be able to communicate guidelines really easily and effectively, so that, Hannah, if you and I are talking in a coffee shop about these guidelines, you would be able to understand what we're talking about. Because science can be tricky sometimes, and it can seem like a lot. But our job as providers and as educators is to be able to make it really easy for our patients and our team members to understand. And so I'm going to summarize it so that it's really easy, so you don't have to be intimidated by anything. And we're going to break it down when dental care is available and when dental care is not available. When dental care is available, there's really no need to prescribe systemic antibiotics or oral antibiotics unless there's systemic involvement. So your patient has really serious fatigue or a fever or some other signs of systemic involvement for their infection. And so if dental care is available, there's no need to give somebody a prescription just in case. You really only need to give them a prescription when it's absolutely necessary. And so that's for when dental care is immediately available. When dental care, or the definitive conservative dental treatment that we've been talking about, is not available, then antibiotics are indicated when the patient has a necrotic tooth. A necrotic tooth is one that doesn't have a pulp on the inside or the nerve on the inside of your tooth that is no longer alive. It's, for better terminology, it's dead. It's no longer living. And so when that happens, and then you have periapical conditions like symptomatic apical periodontitis or localized acute apical abscess, and patients cannot get immediate dental care. Those are scenarios where prescribing an antibiotic is warranted because we're looking ahead and making sure that we're, that infection is not going to progress.
Right. So, for example, in the clinic, there are many cases where patients may come in with a lot of pain in their jaw, but there is no swelling. So what would you do in that sort of case?
It's a really good example. So when we were formulating these guidelines and we were sitting down as a panel, one of the things that we wanted to make sure that we acknowledge and included in the guideline was pain management. Because when you're sitting down and making a decision with your patient and you say, like in the scenario you just gave me, Hannah, look, so-and-so, I recognize that you have pain. The inside of your tooth or the nerve inside of your tooth is very inflamed or irritated right now, but there is no sign or indication of an infection. And so an antibiotic is not warranted in this case. But I do recognize the fact that you are a human and a patient, that pain is uncomfortable, and I want to make sure that I address that. And so what we talk about in the guidelines is a 2018 systematic review where they talk about different pain management therapies and their safety and their efficacy. And when this happens, what we're finding is that the best therapy in this case is combination therapy. And I'm going to just ask you guys to raise your hands. How many of you guys have heard of combination therapy or know what I'm talking about when I mention combination therapy? Okay, good. That's basically everybody. So in dentistry and much of the country has moved away from the use of opioids. And so now what we found is one of the safest and most efficacious combination of drugs is 400 to 600 milligrams of ibuprofen and 1,000 milligrams of Tylenol. And so making sure that you communicate why your patient does or does not need an antibiotic, but then you recognize their symptoms and treat those safely and efficaciously, that's what I would recommend for that patient, and that's what this guideline supports.
Okay, awesome. And just another question. So what if a patient comes in maybe at the end of the day of a dental clinic's regular office hours, and they come in with pain and swelling, so definitive dental care is available, but maybe at a later time rather than immediate care right there and then?
Then that would be the same for the guideline for when definitive dental treatment is not available. And so this is going to happen to you. There's going to be times in practice where they may call you on a long weekend, or you may be away on vacation, or the patient may walk in at 5 o'clock and say they have a flight in an hour, and I can guarantee you that will likely happen to you. It's happened to me many times. And so whether it's those scenarios or more of an access to care issue where the patient actually physically can't get there, or there isn't a provider in the area, or they're using an emergency department for dental treatment, those all fall under the guidelines of when definitive dental care is not available. And so you would follow that algorithm. I am going to pull it up, I think. Yep. So it's the orange one, if you have it in front of you. But what's fantastic about these chairside guides that are actually located on our website, ada.org/antibiotics, is that we've made it really easy. We want to make sure that if you're chairside with a patient, you can help make these decisions really quickly but well by applying the evidence. And so what we've done is we've actually created an algorithm where it's basically a decision tree, and you can kind of walk through and say, this is what I'm finding in my patient. These are their diagnoses, and these are what the recommendations are. And so in that case, Hannah, you would use the orange one where definitive dental care is actually not available, and you would follow that decision tree in order to help take care of your patient.
Right, and that's really great that you guys came up with this decision tree, because I feel like as dental providers, a lot of dentists tend to be more visual learners. So to be able to have something to flow along very easily with that, especially if you're right on the spot, trying to make a decision, that's really great to have.
Well, and one, it's about learning and being a visual learner, but two, it's about shared decision making. Can you imagine if you were a patient and you sat down with your patient and you said, hey, we're going to walk through this decision tree together, and we're going to see what the risks, benefits, and alternatives to treatment is, and what the evidence recommends at this time, and I'm going to educate you while we make this decision together. That's a really fantastic way to communicate with patients, but also to have buy-in when you are talking to them about their treatment and treatment possibilities too.
Right. Oh, that's great. Thank you so much.
Yeah.
Well, who is the intended audience for this guideline?
Well, dentist, obviously, is the first. I didn't even get a laugh. Wow. Tough crowd. So dentist, obviously, as you can see, we're talking about tooth pain and swelling inside your mouth. So it's definitely indicated to dentists, dental students, dental educators, dental researchers, all of the specialties in dentistry, dental team members. But more importantly, I think when we're talking about tooth pain and swelling, we have to recognize that many, many, many patients are seeking emergency care either in emergency departments or primary care settings. And so what we're actually doing, what the ADA is working on over the next couple months, is taking this guideline that has a lot of dental terminology, and they are going to put it into terminology that can be easily used in an emergency department or a primary care setting so that we equip all members of a patient's medical team to be able to communicate and treat patients efficaciously and really safely. And so we recognize that this is a need that we need to do in dentistry to equip all medical members to be able to take care of our team. And so that's what we'll be doing. So keep like on Twitter, all your things. You need to make sure you pay attention because those guidelines are going to be coming out and in the next couple months.
Right. That's amazing. That's really great to hear. Thank you so much. Well, that wraps up for our conversation with Dr. Kennedy right here, just for now. And we are available to take any questions or comments from the audience, as well as the viewers who are online as well. So our first question is from Jeff on Facebook. Does the guideline consider those who might be allergic to antibiotics?
Absolutely. And one of the main points that we really drive home in this guideline is this idea of identifying true allergies. When it comes to penicillin allergies, I don't know if you know, but about 10% of the population reports a penicillin allergy, but only about 1% has a true penicillin allergy. And so when that happens, it's not just that we have to give them a different antibiotic, it's that we're not able to give them first-line therapy. And a big piece of antibiotic stewardship is giving them the best drug first. And so one, we recommend the identification of a true penicillin allergy. And then we also provide alternatives for prescribing antibiotics for people that do have a penicillin allergy. And we promote drugs like cephalexin and azithromycin before drugs like clindamycin, especially because we're finding so many, as we talked about earlier when I was talking about C. diff or Clostridium difficile and the Peggy Lillis Foundation, we're finding that to be an urgent public health concern. And so steering away from drugs that are more at risk for causing adverse outcomes like Clostridium difficile is something that's really important. And you will find this not only in the guidelines, but in your little charts here. And so you'll actually find all the information you need to be able to kind of reroute around a penicillin allergy right here on this algorithm as well.
That's really great, and I feel like that really changes the mindset because if someone's allergic to penicillin, our automatic response is to go to clindamycin as our second option, basically. So that really does change what we've been thinking so far.
Absolutely, and there's so many mind shift changes that are going to be coming out of this guideline in dentistry, and not only is it the one that you just mentioned, Hannah, but also just shifting away from this idea of just giving an antibiotic just in case to really only prescribing antibiotics when they're absolutely necessary.
So it seems like we have a question from the audience.
I like it.
Can you state your name?
Yeah, I'm Chris Woodard. I'm a fourth-year dental student here at Midwestern.
Welcome, Chris.
So I think most people here would agree that antibiotic resistance is a major issue with antibiotic use. So I was wondering how the guidelines address antibiotic resistance and other side effects that might be seen.
Yeah, absolutely. That is a fantastic question and one that's very forward-thinking because when antibiotics are prescribed, as you can imagine after what we've talked about today, there's indications where it's appropriate to prescribe an antibiotic and when it's inappropriate to prescribe an antibiotic. And the challenge in dentistry is that research shows that depending on where you're looking in the study that you're pulling out, about 30% to 85% of antibiotics that dentists prescribe are inappropriate. And so as you can imagine, over the course of all providers across the country, that would make a huge impact and contribute to patients taking antibiotics when they're not necessary. And when you take antibiotics when they're not necessary, or even when they're necessary, what can happen over time is that certain bacteria or pathogens can become resistant to those antibiotics, or they're no longer susceptible to the effects of those antibiotics. And patients, in turn, can then develop infections that are really challenging to treat, or in some cases, unable to be treated. Right. And so not only is this costly to the healthcare system, but it's costly to our patients, and it puts them at pretty severe risk. And so the more tools we have and the better guidelines that we have and the more guidelines that we have, and this is a plug for us developing more guidelines around antibiotics, the more guidelines we have, the better we can drive prescribing to really be only appropriate and less inappropriate prescribing, so that over time, we can make a huge dent on the effects of antibiotic resistance in this country, and really globally. And ultimately, I know it doesn't seem like a really small decision that you're making maybe over the course of 30 seconds with a patient encounter can save lives, but I challenge you to go to the Peggy Lillis Foundation website, because all you have to do is click on 2 or 3 bios, and you'll realize that that small 30-second decision that you make with one of these algorithms could save a life. And so not only is antibiotic resistance on the forefront of research and policy focus right now, but it really should be on the forefront of what we're thinking when we're treating each and every one of our patients.
All right, that's great, and thank you to the Peggy Lillis Foundation for being able to come up with an organization that supports that. So
absolutely.
That's awesome. We do have another question from Dana on Facebook. How can I use the guideline to educate others?
Oh, well, there's a couple things that you can do to help educate others by using this guideline. One, I think I said it before, but I don't know if you caught it on Facebook, but you can go to the website ada.org/antibiotics. There you're going to find the guideline. You can download it there. You can download you can make printable copies of these for your operatories. These are the chairside guides. And also there's going to be a clickable algorithm that you can use, which is fantastic. So what you can do there is in your operatory or in your office, you can actually click through the patient scenario that you're going through, the signs, the symptoms, the indication, and it will actually help you apply evidence-based dentistry or evidence-based medicine to the decision that you're making right there. But more importantly, and I want to highlight this, we have patient education resources. So we have downloadable forms that you can actually give out to your patient to educate them, and we've made a video that can talk to your patients about that it's okay that there are some indications where they're not going to receive an antibiotic. What's a really big deal when we release a guideline like this is when it's been different than what we've done in the past. So if a patient, every time they've had tooth pain for the last 20 or 30 years, they've gone into a dentist, they've received an antibiotic. Now all of a sudden you're a dentist who's not going to be doing that because you're applying evidence-based medicine. That can be a tricky conversation. And so what we've tried to do is equip each and every provider, educator, dental team member across the country with the tools and resources they need to communicate with these patients. And so that involves, resources and videos and teaching tools so that you can make shared decisions in your operatory.
All right, thank you so much. If you have any more questions from the audience, please feel free to come to the front. We do have a question from the audience.
Hi, I'm Nikki. I do have a question. If I went to the dentist and I had pain, are there any instances that I might not receive immediate care?
Yes, there are examples of that. For example, let's say you go to the dentist and it is a Friday night or a Saturday morning or something along those lines, and it's an emergency procedure, right? And you come in, you might be screened or you might receive an emergency examination, but time for treatment or availability of treatment might be delayed a few days. And so that's a really good example of when you might come in, you might be screened, they might be able to diagnose your condition, but you may not receive an antibiotic right there. In that case, it goes back to what I talked about before, where we recognize that an antibiotic's not indicated, but we then go through with pain management. And pain management in this case would be combination therapy again with the ibuprofen and the acetaminophen.
Okay, awesome. And then a Facebook Live or Facebook online question from Pamela. Do the guidelines address the age of the patient, such as children or the elderly?
So the guidelines, that's a fantastic question. So the guidelines address adults age 18 years and older, and they are immunocompetent patients. So patients that do not have like a severe like immune challenge, for example, someone undergoing chemotherapy in that case. So in any adult age 18 years or older, it will address that as long as they're not undergoing a procedure or have a condition where it severely immunocompromises their system. And what's fantastic is if you download the guidelines at ada.org/antibiotics, and if you haven't figured it out yet, I want you to go there. There's a fantastic table that helps you list every single condition that would actually put the patient in a category of being severely immunocompromised. And so I think for dental students, that's something that's going to be really helpful. If anybody in here is going into a residency, raise your hand. Are you anybody going into a general practice residency in a hospital or an AGD? Okay, a couple people in the back. That table is actually going to be really helpful for you as you embark on this new journey of working in a hospital and working with immunocompromised patients, but specifically this guideline addresses adults.
Okay, awesome.
Yeah.
And it seems like we have a question from our live audience. Can you tell us your name?
My name is Kayla Yuk, I'm a D4. My question is, say you have a patient come in on urgent care and they're already taking antibiotics, and according to the guideline, it's not indicated that they should be. What's sort of the plan of action?
Yes, so that's a fantastic question. So in your case, they may receive dental care that day, right? One of the other mindset shifts that this guideline brings to the surface, I would say, is this idea that you don't have to take a full course of antibiotics. In the past, and I'm sure almost anybody in this room probably remembers a time where when you received an antibiotic, the thing that was harped on you before you left the doctor or the dentist's office is that you had to finish your antibiotic. You have to finish your antibiotic. And we're shifting away from that. So the guidelines suggest actually that you can discontinue the use of antibiotics as long as your symptoms have been resolved for 24 hours. So in your case, the patient came in, they saw you, maybe you started treatment. As soon as their symptoms resolved, they can actually discontinue that antibiotic within 24 hours.
Yeah.
And again, that's a tricky patient scenario where these algorithms and these guidelines are going to be really helpful for you to communicate, because in the past, that patient is going to be determined in their mind, I need to finish this antibiotic. And actually, research suggests that patients are not more at risk for antibiotic resistance if they take the full course. And more importantly, it's not going to really give them any benefit for them to finish that full course of antibiotics. When we talk about antibiotics, we have to remember that there's benefits and that there's harms. And it's our stewardship of those clinical decisions that helps us weigh those back and forth. And what the guideline does is it equips you with science and evidence so that you can partner that with patients' desire and preferences and your clinical expertise to practice evidence-based dentistry. And it's the three of those things together that will help you, in your operatory and help you make clinical decisions.
Right. And that's really great to know, because I feel like throughout our training and things like that, it's something that has been harped about, like finishing your antibiotics. Just that may increase antibiotic resistance, but it seems like it may not necessarily be so that way.
Yeah. So in your patient case, let's say they've been there for 2 or 3 days. They've been taking this antibiotic. You could start treatment the next day. You call, you check up on your patient. You're monitoring them very closely. In the guideline, you're going to find that as interim monitoring is what we refer to that as. So you're monitoring your patient very closely. You're providing them with excellent care. And they say, you know what, Dr. Kennedy, I'm feeling great. Whatever you did was magic. I'm feeling so much better. That's when you have an opportunity to educate again, and you can say, so-and-so, remember yesterday when I said as soon as your symptoms resolved, you can, after 24 hours, you can stop taking your antibiotic? I recommend that you take X dose, and then tomorrow you can go about your way, and you can properly dispose of any antibiotic that's left at your local pharmacy.
Thank you.
Yeah.
And it seems like we have another question on Facebook from Patrick. What is the recommendation for prescribing antibiotics for sinus perforations when infection is not present?
Well, one of the important things, this is a fantastic question, but it's actually not located within the scope of these guidelines. And so I think this is a good time to review what's within the scope of the guidelines so that you know really clearly. So these guidelines are geared towards giving you answers or giving you information to develop clinical answers in the operatory. When the patient has tooth pain that's caused by symptomatic irreversible pulpitis, or a necrotic pulp, that has either symptomatic apical periodontitis or a localized acute apical abscess. And so that's the scope of this guideline, and that's the scope of what this guideline can really offer to you. But what is so fantastic about being a part of the expert panel and the guideline panel that I was a part of is that we debated for hours what the scope, not just what the scope of the project could be, but we actually brainstormed all of the indication for antibiotic in dentistry. And we're filming a CE course tomorrow that will be made available to all ADA members, and so I hope you guys check it out. But we're actually going to go over the tree that we created as a panel, because what we found is that there's so many indications for antibiotic use in dentistry that in order to be able to provide recommendation and guidelines and clear evidence in this case, we had to narrow that question down so that it would be answerable. And what's important is just because a guideline doesn't exist for a condition doesn't mean that there's not evidence. There could be another systematic review, Patrick, that talks about antibiotic use when you have a sinus perforation, or antibiotic use before and after an extraction, which we don't talk about extractions in this guideline. And so what's really important for you to understand is that while guidelines are the highest level of evidence that we can have, and guidelines are what we strive to continue to create at the American Dental Association, what really happens is we have to go out there and continue to build an evidence base for antibiotic use in dentistry and really understand what's out there.
Right,
Yeah.
that makes sense. And we have another question on Facebook by Yusuf.
Okay.
Are these guidelines being shared with emergency room physicians?
Yes, they are. So we have a dissemination strategy to educate emergency department physicians, and we will also be publishing a set of these guidelines in some of their specific professional publications in terminology and language that works for not only their practice, but for their understanding and for their day-to-day.
Okay, that's awesome. Well, thank you so much, Dr. Kennedy.
Thank you, Hannah.
I think that wraps things up for today's event. Thank you so much for both our Facebook audience as well as our live audience here today. And thank you to everyone and Dr. Kennedy. And the ADA is committed to driving dentistry forward on critical issues and developing the best evidence-based clinical information to help you provide optimal care for your patients. If you have more questions or want to explore the clinical and patient resources, visit ada.org/antibiotics. Thank you very much.
Thank you, guys.